that almost every rotation somehow I had him as my attending. And it's just been a blessing in my life, honestly. He's so passionate and so accommodating to all of us students. And I love Dr. Amsterdam. Again, not for his politics. We all agreed no politics, but for what he has done to educate all of us, touched our lives. Ezra.
It's such an honor and pleasure to come back here every year, and I have to thank Mo for that, and also to be so impressed with what he's done, what he's established here, and the program that we see every year. It's absolutely fantastic, and he is a tremendous reflection on UC Davis, and the fact that UC Davis was associated with him is a very nice reflection on what he's done here, and so the reflection goes both ways. So thank you, Mo, for inviting me again. It's a pleasure to speak here, and I will be passionate, but no politics. I had a return invitation, it was a couple of years ago, I think, and it said we would be pleased to have you again speaking on such and such and such and such, but no politics this time. And I was telling Mo earlier, I'm really sorry I didn't frame that letter. That would have been a very nice letter to have. So keep things truly in perspective. This is a perspective on heart disease in women, but the big picture also will keep in perspective and talk about heart disease here, particularly one of my favorite subjects, which is heart disease in women. So the disclosure, I have conflicts, but they were inner conflicts, and I will not share them with you. So let's have some background, and then we'll get into this fresh perspective on heart disease in women in the 21st century. So what happened to the superior sex? Those of us who are a little older, remember women were regarded, and I think still should be regarded physiologically, as the superior sex, but we don't hear that anymore. Life expectancy in women is older than men. A 65-year-old female is considered to be physiologically like a 45-year-old male. We hear these things. Men die younger of all causes, of the leading causes of death, than women. And it's in the mid-30s, women outnumber men in the population already because of the early deaths of men. And by the time we reach any of us reach age of 100, 8-to-1 women to men. And so again, what has happened to this idea that women are the superior sex? We don't hear that anymore. And it's really interesting if you read the obituary pages. I read the obituary pages faithfully, for instance, in the New York Times, because it's history. And people giggle about it, oh, it's morbid, etc. No, it's not morbid. It is actually American history, and it's world history. The obituaries in the Times are fantastic, but whom are they on? And what do you read about? You read about he is survived by his wife. And if a woman dies, the obituary says she was preceded in death by her husband. Almost always. I mean, you women, you know that. You're aware of that. So I had a patient once. How did it work? The woman was about 10 years older than the man in this very nice couple. And we talked about the age. It was an unusual age discrepancy. And she said, oh, when we got older, I wanted him to take care of me. I didn't want to take care of him. So because she knew that she would be living longer and she wanted him around. So she set it up that way. But seriously, let's look now at death. You hear at all ages, a leading voice in American cardiology a few months ago said, quote, the sobering fact is that at all ages, heart disease is the leading cause of death in women. Here are the data from the Center for Disease Control. On the vertical axis, we're looking at percent. This is deaths in men in the U.S. previous decade. We're always a decade behind in these statistics. Blue bars are cancer deaths. Red bars are heart disease deaths. In men, you see, at all these ages on the horizontal axis, the red bar exceeds the blue bar. That's for males. Heart disease in men exceeds that in women for mortality. For heart disease exceeds that of cancer for mortality. How about in women? Now, where is my slide in women? The slide in women, I went through all my slides beforehand. In women, you will see, I don't have it, I'm sorry. In women, you will see the blue bars exceed the red bars until the age greater than 75. This is still men. But this would be the reverse in women. At all ages younger than 75, the mortality from cancer is higher in women than it is the mortality for heart disease. Then when the over 75, the female's heart disease becomes the leading cause of death. And it is so great that if you average it over the lifetime, you can say that heart disease is the leading cause of death in women. But not until the age greater than 75. And yet we hear people saying at all ages, mortality is greatest from heart disease in women. So not true. And here I would ask, have we gone too far regarding gender differences in heart disease? Here, a 54-year-old woman came to our clinic. She had had an angioplasty for typical angina. She came in six months later for one of her visits, and she said, "Doctor, I threw out all my nitroglycerin pills because I saw on TV that women with coronary disease don't get chest pain. Is that okay?" So, and this is what we see, that women coming in with a lot of bizarre symptoms, and women do have a higher rate of atypical symptoms than men. But most women get typical symptoms. The rate of atypical is higher than in men, but most women, when they have a heart attack, have typical symptoms, not pain in the knee or in the toe or a headache. That has been overdone. In fact, elderly, you see atypical symptoms of a heart attack in the elderly, primarily in the elderly. And when do women, except in exceptional circumstances, when do women get severe heart disease, coronary heart disease, die of coronary heart disease? In the older age populations, after the menopause, 10 years after the menopause. At that point, men don't have menopause, but at that age, the males are also having atypical symptoms. But the majority of men and women in the elderly group who have atypical symptoms, the majority have typical symptoms. So I want to make that a very important point. Women generally have typical symptoms. So let's look at the epidemiology, then management, risk factors, clinical presentation of women with heart disease, stress testing, and then the unique pathophysiology of CAD that has been proposed in women. Epidemiology, but you have to help me. You have to help me now. I take a little break. Select the proper choice of these three. The major cause of mortality in women less than 75 years old is, and I have already given you the answer, less than 75 years old. It is CVD. Is it CVD? It is cancer. So while I was preparing this in a hurry, I got the wrong answer. I got it wrong. That's just a test. Just a test for you guys to see if you're on the ball. This is the wrong answer. Under 75 years old, it is cancer. It is not CVD. It is not both of them together. So here's the slide I was looking for. Notice the blue bars. Notice cancer, percent mortality in women, age 35 to greater than 85. The blue bars exceed the red bars, that's cancer, until over 75, then heart disease becomes the leading cause in women. Not before. That doesn't mean we don't need to be careful and prudent with lifestyle, diet, the things that Dr. Kopecky talked about earlier and the others have talked about in terms of risk factors, because coronary disease smolders below the radar for decades before it expresses itself as sudden death or myocardial infarction as the first manifestations in most people. The majority of the initial manifestation of coronary heart disease is sudden death or myocardial infarction. The lucky ones have stable angina. And that's how it is with women and men both. But women, this does not happen until generally over the age of 75. A trickle comes in at younger ages, and those are women with very high risk features. But the preponderance of the data of mortality in women is greater than the age 75. That's the area right here, right here. This is a very sensitive scroller. Okay, so I have a question now for the audience. This is a very big room full of seasoned clinicians who have seen a lot of cardiovascular disease. How many of you know, have taken care of, have been familiar with a woman, not a diabetic, not a smoker, premenopausal? The average age of menopause is around 51 years old in this country. How many of you know of such a woman, young, premenopausal, non-smoker, non-diabetic, who has had a myocardial infarction? It's not zero, and that's exactly the way it is. I have asked this question around the country. There were at least 3 hands, 4 hands in several hundred people here. That's typical. Same question. Know a woman, have taken care of a woman under the age of 50 who had or died of breast cancer. So, I rest my case. It's cancer. It's not heart disease in the younger population. We should be careful, though, because heart disease catches up with us. As I said, it smolders below the radar until it progresses to the point where it expresses itself in medical disasters. But you just saw what the experience is here. It was more than 10 to 1, cancer over heart disease in the patients the hypothetical patient I posed. So coronary heart disease is rare in premenopausal non-diabetic women who do not smoke. Rare doesn't mean zero. And as you saw, there was a sprinkling of people who have seen such a person. This is an interesting paper, not too many years ago, the bottom in green, of almost 300,000 MIs in women. 2,400 were less than 54 years of age. That's that young population. But it was less than 1% of the MIs in women in that study over 1 year. Less than 1%. So it happens, but it's uncommon. Yet we have leading figures in this country devoting their lives to heart disease in women who, for whatever reason, say the leading cause of mortality in women at all age groups, the sobering fact, is cardiovascular disease. So here's some more data on the accelerated diagnostic protocol. These are the low-risk people who come into the ER with chest pain. They are the majority of people who come to the ER with chest pain. Low risk, come in, they're stable, they've had chest pain, they're clinically stable, no arrhythmias, blood pressure is good, EKG is normal, first troponin is normal. They immediately become categorized as low risk in our population. They're unlikely to have an MI with serial troponins, and they generally go to our chest pain unit. They're triaged from the ER to our chest pain unit. So here's a study we did recently on 212. They were the kind I'm talking about. Young, no diabetes, no smoking. They had a negative chest pain unit evaluation. In the chest pain unit, some of them had another troponin, more ECGs, some didn't. A large group were tested. They either had stress EKG, treadmill test, or a few of them had nuclear or stress echo. They all went home that day within a few hours from the chest pain unit. 5 years later, 2 to 7 year follow-up, none had any CAD events. Now, this is politically incorrect out there. This paper has been submitted for publication, and it's going to be really interesting to see how it does. Obviously, it has to pass muster on all the usual criteria rigorously that we judge all papers, but depending on who gets this to review, it's hard to keep some politics, not the kind I talked about here, but some politics out of science. Politics, this doesn't support a lot of grants for some people. So we'll see what happens. That was okay politics, wasn't it, Mo? That was all right. Yeah. That wasn't about Hillary or what. Oh, click it. Yeah. Thank you. Okay. So I've kind of ranted a little bit here, and now we'll look at the other side of the coin. Men and women with CAD and with infarction. Let's look at some of the other things that I haven't talked about yet. Women, when presenting with an acute coronary syndrome, an MI, or unstable angina, are older, have more comorbidities, more diabetes, more lung disease, more kidney disease, more hypertension. The diagnosis is delayed and therapy is not optimal. That's been true into the first decade of this century. That's partly women don't present. They stay home longer than men before they go to the ER. And also, we don't or didn't deliver appropriate therapy in a timely manner. The therapy was less intensive in the women. And a recent study, just a couple of months ago, in British Medical Journal, in Circulation, indicated that women who come in with an MI have greater emotional stress. There's a greater burden psychosocially. They have care that they give. They can no longer, they're worried about that. They're worried about relationships. They're worried about a number of many factors that don't seem to trouble men as much. And this has an adverse effect on their recovery at 1 month after the MI. How they feel, what the mortality is, and how they do in terms of their rehabilitation. Rehabilitation, big R, capital R. All patients with cardiac disease, newly evident, bypass surgery, stenting, MI, should be going to rehab. And also, Mo and I talked about peripheral arterial disease. That's a big thing up here and down there in Sacramento. PAD patients should be going to cardiac rehab. It has tremendous benefits to these patients from a variety of factors. So, talked about epidemiology, made the points. Now, management. I alluded to some management. And here we're looking at from about 1980 into the end of the first decade of this century. The vertical axis is deaths, deaths in thousands. So the top would be 530,000. The blue line is males. The red line is females. And we used to talk about how, over the last 30 years, mortality from cardiovascular disease has been going down, puff our chests out, very proud, new therapies, advanced therapies, risk factor modification. But when it was looked at carefully, men and women separated, it was the males who were getting the benefit, and the female curve really wasn't coming down. In fact, it was rising a little bit. That was up to 2000. That was as we entered the 21st century. Now, to demonstrate that, you can see here therapy back then, acutely on the left, and at discharge on the right. Both are very important. Better use in men, greater use in women. All of these things were standard therapy given to acute MI patients then. And these dots and the little horizontal bars indicate that to the left of the line, it was about 25% better, more intensively given in men than in women. None were given more intensively in women. At discharge, aspirin, beta blockers, ACE inhibitors, and statins all were clearly given more to men than to women. And that was reflected in what I just showed you in terms of women not benefiting from these advances. So recent guidelines, starting with early in this century, recommending women and men should receive the same treatment for cardiovascular disease. The same. So one of my messages is there aren't a lot of differences in heart disease in men and women, except women get it later, Earlier, do better, get it less. But therapy should be the same, and you'll see more that I'll say is the same. Notice the curve I showed you just a little bit ago? Well, here, men keep benefiting right through, and that's continuing right up until we're almost entered this decade. And how about women? All the attention, the guidelines, Go Red organizations like this, these movements, women have benefited even more, faster than men in the last 10 years. So that's a big change. There was a basis for being very concerned about the lack of attention, emphasis on good medical care for coronary heart disease in women. And that has changed. That's a very good thing. So am I wearing red for women? Yes. However, I'm also wearing black for men. What about men? Depends. This is really political. Depends on where I give this talk. Sometimes I don't am I wearing red for women? I say no. I'm wearing black for men because women are doing better than men. Now women are doing better than men. But let's just wear red and black and keep it even. Okay? Okay, risk factors. Now, that was a big deal, the issue of risk factors for heart disease in women and men. How are they comparing? So now I'm going to ask you to help me. The treatment of cardiac risk factors in women differs from that of men. We would have answered that in the past as true. That's false. It's very similar because the risk factors are very similar. Here's what Lori Mosca, that's a female name, Lori Mosca, she said a couple of years ago that evolving science suggests that the overwhelming majority of recommendations to prevent CAD are similar for women and men, with few exceptions. Few exceptions. So it makes you kind of wonder about, the preventive cardiology, women's preventive cardiology clinic. Do we really need a woman preventive cardiology? We need good preventive cardiology clinic for women and men. But there may be a case to have it for women. It attracts women. It'll draw more women into the scene. So that would be one factor that would support the fact that you have a women's preventive cardiology clinic. We have one at UCD. I don't know whether you guys have one, preventive women.
We do.
Yeah, so that women are more likely to come in and address their risk factors and other cardiovascular factors in a devoted clinic than if it's just a preventive cardiology clinic. So that point can be made. So this is a study from Europe, in Germany, and we looked at gender differences in patients with myocardial infarction. The point I want to make out of this is what they said, adjusted for age, gender is no longer an independent risk factor. There was a lot of papers saying women were at higher risk than men. And this was a study, like others, that said there's no difference in men and women. What about the clinical presentation? Women, as I said, are like the elderly, because women are mostly the elderly when they get expressed coronary heart disease. They do have more atypical symptoms. I already dwelt on that. But the majority have typical symptoms, bold font, and capital letters. Majority have typical symptoms of angina and acute coronary syndromes. Now, this is one I really need some help on. This is done by a very good group. There are very good names in here. William Bowden, he was the head of the Courage trial, a very important trial. Leslie Shaw has done a lot of data on stress testing in women. Martha Gulati is excellent. I'm on a committee with her, Gary Heller. So they did a study looking at signs and symptoms of suspected myocardial ischemia in women. The results from this paper was the results from the trial is a little bit awkwardly named. What is the optimal method for ischemia evaluation in women trial? It was a comparison of nuclear stress testing and plain treadmill stress testing. And what they got out of this, and the bottom line, really baffles me. And what it said was women reporting frequent angina were more likely to exhibit ischemia. And this, okay, that's fine. I would think that's right. And then they concluded This may characterize a female-specific, typical angina pattern. The more angina you have, the more likely you are to have a positive stress test, nuclear or treadmill. That's specific for women. So I agree with this guy. And I will tell you, the word here, I had to do a little doctoring here, because that's not the word that was there on Google. But I have to agree with him. I do not understand. So if men have a lot of angina, that's not likely to be more associated with a positive stress test in men, only women? I don't get it. I agree with this guy. All right, so some of the stuff that has come out, straining to make differences in women and men. So, however, here we go, differences in women and men. What do we see here? This is the left ventricle in diastole, and this is the left ventricle in systole. Nothing's happening here. It is a balloon. It is the apical ballooning syndrome. The base of the heart is contracting very well. It is Takotsubo syndrome, more common in women under physical or emotional stress. What about coronary artery dissection? Both sexes, more common in women, particularly in the peripartum age group, but more common. And we've seen a few of those in women. We published one, or it may be in press. It's a case, and it's named, they want you to give these clever, cute little titles in the American Journal of Medicine. It's called Pain at the Game. This woman, 34 years old, got into an altercation, not physical, but an altercation with another parent at a daughter's baseball game. The kid was 10 or 11 years old. She got chest pain, came to the hospital, coronary angina, she had ST elevation MI. Pain, went to the cath lab. It was a coronary artery dissection, an LAD dissection. It was not fixed. She was treated conservatively, and she's done well. 2.5 years later, she's doing well, but very concerned, and that was a typical female event. Connective tissue disorders, lupus, periarteritis, rheumatoid arthritis, more common in women and associated with a very pro-inflammatory state. Coronary disease in that group, more common in women. Syndrome X, the so-called normal or non-obstructive CAD with anginal syndrome. We'll talk about that in a little bit. Now, polycystic ovaries are associated with increased risk factors, but so far there's been no documentation of increased coronary disease. It's important to recognize that. So far, we have no documentation that the increased risk factors in polycystic disease are associated with coronary artery disease. It may be because those have been picked up in relatively young women who haven't been followed long enough. So we'll see what happens there. Best choice. Okay, this one I haven't given you the answer to yet. Let's see if you know. The value for normal troponin is the same in women and men. So if a woman comes in to the ER with chest pain, a man comes into the ER with chest pain, blood is drawn, troponin is measured. Are those results measured against the same lab normal? Are there different normals for women and men? No. So the value, so the answer to this would be this is true. This is true that they are the same. However, going backwards, Mo, trying to go back. Okay. So that was true. Now here's a study. It's recent and it may upset the apple cart. This was a study done, published in the British Medical Journal. It's very recent. 622 women, 500 men, so over 1,000 patients, using the new high-sensitivity troponin assay that they have in Europe and Asia. And what was shown, very interestingly, I can't even do it if I'm just pushing the button. I'm having a problem here. All right, so the diagnosis of MI by troponin. This is the conventional, the old. 11% of the women that came in with chest pain had an MI. Almost 20% of the men by the standard lab value had an MI. But when they looked at the high sensitivity troponin assay, they did both assays on the same blood draw. The women, twice as many women had an MI by that high sensitivity, whereas for men, it was about the same. The frequency of MI was about the same. And they're suggesting that maybe we need to have different values of the new troponin for men and women, normals. And I'm saying it may have nothing to do with men and women, but with body mass. Men are bigger than women, so women may need to have a lower, I don't know if it's true, but consider that it's done by body mass, whether you're female or male, because all of our doses of drugs and all of our lab values, many of them that are not done in terms of body mass, should be done in terms of body mass, and we would be fine-tuning our data much better, I think. So that's an interesting recent study. Stress testing, very important. Okay, best choice. Stress testing in women to detect CAD should be performed by myocardial perfusion stress scintigraphy, a nuke, exercise stress echo, or treadmill electrocardiography. Now you guys can participate. So we don't have the audience response now, but I'd like to see a show of hands for the nuclear stress scan should be the test. No, the guys, see, that's what's great about the audience response. You're anonymous. It's secret. You can't get embarrassed. Can't get the wrong answer. Exercise stress echo. Okay, we have a few there. Treadmill electrocardiography. A few more courageous souls, and I commend you. Correct answer is treadmill, based on data and based on guidelines. This is probably one of the most violated recommendations in cardiology. All the guidelines of the ACC and AHA recommend, this is one of the guidelines, in patients with stable ischemic heart disease, patients in the chest pain unit, whatever, suspected, if the patient is able to exercise, the baseline ECG is normal, the standard treadmill is a 1A recommendation. Great recommendation means should be done, it works, and A means it's supported by randomized lots of trials. Limited exercise capacity or an uninterpretable baseline ECG, then we do a stress imaging test, either exercise or pharmacologic. The data is not quite as strong, still very adequate. So that's what we need to be doing, and we overdo stress imaging. And by the way, nuclear stress testing has a fairly high radiation dose. The old thallium that we used to do, in terms of a number called millisieverts, it's up in the teens. That's a huge radiation dose for a test. Tests like computed tomography, coronary angiography are below 5. A chest x-ray is way down. But radiation, nuke stress, it's a great test, but it should only be done when indicated and not in a loose manner. So let's look at the comparative effectiveness of the plain treadmill with or without stress nuclear in women with suspected CAD. Over 800 patients, intermediate to high risk for CAD. Leslie Shaw was the primary author, published in Circulation. So this is a premier paper. The idea was to see which is better, which prognosticates better, the plain treadmill or the nuke study. And the bottom line of that paper was exercise treadmill was as accurate as the nuclear study in predicting 2-year outcomes, mortality, myocardial infarction in women with chest pain, and was much cheaper. So if we know how to use treadmill testing with ECG, we save money, we save radiation, which is particularly important in younger people who are being radiated, in their 40s or so. So let's think about that. Now, here's some data we did, and this was a student. Brittany Chatterton and I did at UC Davis, and we used the Duke treadmill score. You make a score, we have it on all our treadmill reports, and it uses whether the patient gets chest pain on the treadmill or not. It also uses how far they go, how many minutes on the Bruce treadmill score, and it also incorporates how many millimeters of ST depression, and it integrates them. It's very simple, and we just punch the numbers in and we get the Duke treadmill score. It's a very good prognostic indicator. And what we found, the major factor here, what we found was as you go from right to left, you're looking at major adverse cardiovascular events over a 6.5-year period. We followed these women. On the right are very high scores. Here, a very high score is good. Very high score is good. Notice trivial number of events. I mean, a myocardial infarction is not trivial, but the number is low. And as we go to lower and lower Duke treadmill scores, the event rate goes higher and higher. And the driving factor in the Duke treadmill score I named exercise-induced chest pain, the ST depression, and functional capacity, how many minutes they could go on the treadmill. The latter is what drives this score. So functional capacity is the single most important predictor of all-cause mortality. All-cause mortality, it includes cancer and other diseases, not just coronary disease. That's the key here. It trumps the EKG. So this was, I like not to have even numbers. So it was 1,001 women presenting with chest pain. Very important. So again, the value of this was a plain treadmill. So finally, what about this unique pathophysiology, a so-called microvascular disease? And it's been sort of promoted as a women's disease. It's below the radar of the coronary angiogram. These are men and women, but predominantly women, 2 or 3 to 1, come in with angina, go to the cath lab, and have either coronary angiographically normal coronaries or non-obstructive CAD, that is, less than 50% narrowing of a major coronary artery. So let's see. So most of the emphasis on differences in men and women in coronary vascular disease has focused on endothelial dysfunction, which is the underlying factor in coronary microvascular disease, abnormal vasomotion in the coronary arteries. Other things have also been considered, but endothelial dysfunction, microvascular has been the key. And the very important paper published from Cedars-Sinai by Noel Berry Mayers and her group at Cedars is shown here. It's a little bit complicated. Event-free survival. So the higher the number, the higher the line stays, the better. Means a higher event-free survival. And the curve is broken, starts at 0, and this is 100% at the top. This is over 6-year period. Now, we'll ignore the bottom 2 lines because those are people who had obstructive CAD, and they did badly. Whether they had chest pain or not, they did badly. And it's interesting, if you see they had obstructive CAD, whether they had ongoing chest pain or not, there was no difference. It was a CAD that did the deed. Now, these are the important. The top orange line showed a pretty good outlook. These are patients that had either normal coronary angiograms or non-obstructive CAD. So the orange line or yellow line is shown here. No chest pain, no CAD, that is no obstructive CAD. And they didn't have continuing chest pain. After the angiogram, they were told you don't have enough coronary disease to really have a stent or a bypass surgery, or your coronaries are normal. Their chest pain went away, and we've seen that since the early days of coronary angiography. They had not a perfect outlook, but a good outlook. Then there was the group that had no obstructive CAD, that's the brown line, and persistent, still continuing chest pain. And they had a significantly greater event rate, a lower event-free survival. This was a big difference. So neither had obstructive CAD, but the line on top, that group had no continuing chest pain, and this group had continuing daily or weekly episodes of what we call angina. And that became a basis for saying, you see, these are all women. They didn't have to have obstructive CAD, but they had events, and their chest pain is telling you something. And we may be seeing the evidence of their microvascular disease. Now, they didn't study microvascular disease in that population. So we said, this is very interesting. So we looked, this is their line, the one that didn't do well, that had continuing chest pain. So we looked at our patients the best we could, not like that. We didn't do coronary angios in everybody, but everybody has a series of men and women who continue to have chest pain over the weeks, months, and years with no obstructive CAD. And we looked at our women, and we've been following them also for over 6 years now. And this is their event rate. This study is incomplete. It's a work in progress. And we can't replicate that study. Our women with chest pain who have either negative non-invasive studies or who have normal coronary angiogram are doing very well over this period of time. Different patient population, different centers, different approaches, but we cannot replicate that study. And they haven't either, and their original study was published almost 10 years ago. So that's up in the air and a very fascinating area for study. Now finally, the issue of they have only studied coronary microvascular disease. These are the vessels you can't see on a coronary angiogram. They're very small, but they control a lot of what goes on in the circulation. So this paper was published initially as an abstract in 2012, and this last year came out as a full paper in JACC. Gender effects on coronary microvascular dysfunction in patients with suspected CAD. So a large group of population of patients, over 300 women, around 100 men came in with chest pain that was suspicious for angina. They all had coronary angiograms. Nobody in this population had obstructive CAD. A lot of them had normal coronaries. Some had non-obstructive CAD. The red bars are women. The blue bars are men. Normal coronary flow reserve, just take that as an index of the microcirculation is normal. The small vessels are acting normally. There's no disease that can be detected. Two means that under certain physiologic stresses or inciters, they can double their coronary blood flow. And 2 is normal. And you see in this population, most of the people could double or even greater than fourfold their coronary blood flow. Abnormal coronary flow reserve, which means disease abnormal coronary microcirculation, is less than 2 and fewer patients there. This is the frequency. And notice, though, that the red and blue bars are not significantly different anywhere. There's a little higher red bar here, a little higher blue bar there. There was no significant difference. And for me, that's where the field stands right now. This is the only study up to this point that I know where the studies that are being done in women at Cedars, that's what they do there. They're all on women. This is the only study I know in men and women that showed the disease, the abnormality in the microcirculation occurs in a minority of people who have anginal type chest pain and no overt obstructive disease in the vessels you can see on a coronary angiogram. It's in a minority, and the frequency is the same in men and in women that are studied. So, sorry, I keep forgetting, Mo. So I'm going to go back one and say what we're doing now is we're looking at chest pain and non-obstructive CAD, only study that's been done like this. It is more common in women than men, but we have taken over the last 10 years, in a 4-year period, 2004 to 2007, 459 patients. They came in with chest pain. They got cathed. They had non-obstructive CAD or normal coronaries. It was more women than men, as all these populations are, and they will have follow-ups of 2 to 9 years, and we'll be looking for mortality and major adverse cardiac events, stroke, myocardial infarction, revascularization. We'll be comparing men and women with non-obstructive disease over a fairly long period. And right now, that's the only study I know that compared men and women. It's clear that more women than men have chest pain with non-obstructive or normal epicardial coronary arteries. But men have it too, and we'll see what happens to them over this period of time. So in summary, cardiovascular disease is the chief cause of mortality in both sexes, but it's the chief cause in women. But cancer is the chief cause of women in men under 75 and women under 75. Men, it's heart disease under 75. Women, it's cancer under 75. Risk factors for CVD do not differ in the two sexes. The exercise treadmill, first test for the assessment of chest pain in both sexes. Then you can use stress imaging if the treadmill doesn't apply. Treatment is improving in women, markedly improving, reflected by the marked reduction in mortality and heart disease in the current decade. And treatment should be the same for in most cases, for both men and for women. And coronary microvascular dysfunction, that fascinating pathophysiology, as far as it's been studied, it's the same in women and men in terms of explaining the non-obstructive patients who have chest pain, anginal type chest pain, but women have it more frequently. That is true. Thank you. When did I start? When did I?
We have time for questions.
Oh, good.
Okay. I recently went to San Jose because a cousin of mine had a heart attack, and we were all sitting outside, and somebody asked me the question, and said, why do men die earlier than women? And before I could answer, my brother, you know him well.
Very wise man.
Well, I'll tell you what he said. He said, because men die sooner because they kill us. And then when I was preparing a lecture for Go Red, I asked the guys in the cath lab, well, why do men die sooner? And one of the guys said, because we want to die.
That's great. But the women say, or we say about the women, once the man is gone, the women's stress is gone, and they really live longer.
All right, questions for Dr. Amsterdam. You didn't address hormone replacement therapy. I'm sure it'll come up, but Dr. Dietrich.
Do you think that the sensitivity and specificity for standard treadmill testing and treadmill testing with imaging is the same? And if not, how do you explain the apparent lack of difference between the two in predicting outcomes?
Yeah, I've heard this so many, not your question, but my response. Everybody, great question. It is a great question, but we always say, great question, great question. And I'm not falsely flattering you. It's a very important question. How come when imaging, so the question was, how do we explain, first of all, is the sensitivity and specificity of the plain treadmill equivalent to that of stress imaging, nuclear or echo? And if they're not, which they're not, how can we explain what I said and what the guidelines say about picking the treadmill first? And so it gets into a lot of very interesting points. So the sensitivity and specificity for what? So if we say the sensitivity and specificity for detecting CAD, coronary lesions, is clearly higher in the stress imaging studies because you're looking at a reflection of what's going on in the heart, either a wall motion abnormality or perfusion defect. Treadmill is far away from what's going on in the coronaries, the ST segment, that's all we have. The problem with that approach of comparing them is that using the treadmill in terms of just the ST segment is obsolete. That is not a way that we should be looking at interpreting the treadmill test. The Duke score is one way that I mentioned. It includes chest pain, the ECG, and functional capacity. If you look at the Duke score and look at that, then you can, and look at the pre-test probability of the patient, lots of risk factors or few risk factors, you can fine-tune the result on the treadmill so that it approaches that of the stress imaging tests. It gets very close. That's for CAD per se, the coronary arteries. But what do we do when we do a treadmill test? Usually what we want to know is, what's the patient's prognosis? The prognosis. How well is the patient going to do, or how likely to have a heart attack or a fatal cardiac event? And there, what is the major determinant is functional capacity. It's the functional capacity, how much that patient can do. So I urge that we look at the Duke treadmill score and focus on functional capacity. And there are tables you can use. It is not complicated. And actually, a slide that I took out because didn't want to have too many slides, I didn't want to go over, but there was a study of about 40 comparative papers looking at exercise treadmill and exercise stress imaging. The sensitivity for CAD with the treadmill was about in the 70% level. That means it picks up about 70% of people with the disease, misses 25 or 30. And for the stress imaging studies, it was not much higher. It was about 80%. The stress imaging sensitivities go way up when you include people who have already had an infarct. Then very, very high. So they're not that different, even when you look at it just in looking for coronary disease. But when you look for prognosis, and you look at more than just the exercise ECG, which is not a way that the test should be looked at, then you have a very close comparison between these two methods of testing. So it's a very important question.
Question? Yes.
I'm a cardiovascular data coordinator. Just a quick question about the risk of ischemia. When you talk about the prognosis for the stress test and nuclear. At UC Davis, are they just saying mild, moderate? Do they say risk of ischemia? Because American College of Cardiology and NCCR is giving, I think, that one criteria. I'm not getting that anymore.
So if I repeat the question, at UCD, when we do a stress scintigraphy, nuclear, how are we interpreting them in terms of the positivity?
Small, moderate, large.
Well, it's not the risk of ischemia, it's how much ischemia is there. Okay, she wants to know, how do we interpret? What do they say? They will say small, moderate, or large. And that's what's important. If it's less than 10% of the myocardium that's ischemic, then there's no data that shows revascularization improves the outlook more than optimal medical therapy. If it's very large, then that's one variable. Put it into the context of the whole patient that says this patient should be considered for revascularization. And then in the middle, you have that great middling area where you throw that into all the other factors we have about the patient to determine which way the patient goes. In any case, they all should get optimal medical therapy. The question is which patient should get revascularization. If it's moderate and it's inferior, that's a whole different ballgame. If it's moderate and it's anterior, that would be right coronary versus LAD. So we always lean a little more toward revascularization if it's LAD, or I should say coronary angiography, and then we take it from there.
Any other questions? Yes, ma'am.
Yes, a constantly repeated question, and appropriately repeated question. It's the FDA that's holding it up. There are about several companies, maybe 5 companies. The question was, why aren't we using the high sensitivity troponin in this country? It's the FDA. They still haven't approved it. It's very close, but I've been hearing that over and over for a couple of years. But I know it's very close because we're going to be studying all of them at UCD. And there's troponin T, there's troponin I. The FDA is almost ready to let it get into practice. That's what it is. Europe and Asia already is using it. I don't know, frankly, if it's going to be friend or foe. My own feeling is I don't think we need a higher sensitivity troponin. We are not missing myocardial. If we talk about missing myocardial infarctions, I don't want to be full of hubris, but I don't think we miss any MIs at UCD who get to the hospital, get to the registration, or brought in by ambulance, or come through our chest pain unit. It's extremely rare, and it's not the issue of the troponin that we're missing. I think many people would agree with me that if anything, it's the false positive troponin that's the problem, not the insensitivity of the troponin. Troponin is sensitive enough from my point of view, but everybody wants the high sensitivity, and that's, the residents are going to go crazy. But I say, look, we'll live through it. When CKMB came and replaced CK, we said, oh, how are we going to deal with this? Do we have to cath every patient with a positive CKMB? Of course not. Then we don't turn our brain off and look just at one number or one test and decide on a cath. Same thing will happen. It'll be a problem for a while. We will get it. And it probably will be within, I would say, before 2017. I'll be very conservative. I won't say 6 months. Sometime in 2018, 15 or 16. It should happen, or at least be, yes, it should happen. And it will be a foe for a while. People will be going crazy. What do we do? It'll be confusing. Everybody has a positive troponin. And then we'll kind of settle down, just like we do now with the troponin. We don't cath every positive troponin. The universal definition of myocardial infarction uses three things: consistent chest pain with an acute coronary syndrome, a ECG that shows ischemia or infarction, and an abnormal troponin indicating an acute injury. That means up and down or descending, not flat, not high and flat. That doesn't make the grade. So the same criteria will be applied to the new high sensitivity troponin when we get it.
I would like to repeat that because we got called all the time from the emergency room. Somebody comes in for any condition or even for chest pain. Atypical chest pain. And they say, but the patient has a family history, the patient has cigarette smoking or diabetes, but the nature of the pain, the characteristics of the pain is important. If the patient truly has symptoms suggestive of ischemia, along with the troponin and EKG.
Yeah, and that's where this whole atypical thing in women have gotten us into trouble. Oh, you mentioned some of them. Oh, but it's a female. So it is pain in the pinky, but it's a female. So it could be an MI. So exactly that, yeah. So we struggle a little bit, but I think, and the ER, you know, we always like, the next morning we like to say, oh God, why was this patient admitted? Why did the ER admit this patient? But we get the morning after. We're Monday morning quarterbacks, I think, sometimes. They're on the front line, and they are trained and indoctrinated in the fellowships. Your greatest cause of liability is missing an MI. So some of them just say, we had one guy at UCD, he's not there anymore. He said, I don't want to deal with chest pain. I don't want to be sued. Every chest pain gets admitted. Now that's not medicine. You know, that's being a robot. And that's bad medicine. And it's bad for the trainees. So think of it the way we just discussed it in terms of the universal definition. ECG changes, typical troponin, evolving troponin, and the ECG. Now, they can evolve also and look typical with sepsis. So just the troponin doesn't fill the bill. A pneumonia or sepsis, any major systemic cardiac stress, any major systemic stress that affects the heart indirectly can still leak a few molecules of troponin. That doesn't mean it's an MI or a rule-out MI. And that's the challenge to clinicians.
Thank you. Thank you, Dr. Amsterdam. Thank you.
My pleasure. Always my pleasure.
You know, every year I take a photograph with the speakers, and I look back and I see that every year I become grayer and grayer, and Dr. Amsterdam stays the same.
I think the big spot up here gets bigger and bigger. Thank you.
Okay. Dr. Wright needs no introduction. You know, every year he comes, boy, I tell you, overwhelmingly they say he should be a sports news caster, or he should be in television. More importantly, he delivers a great lecture with great content and great education. Rich?